Good afternoon, everybody. My name is Jun Yan. I'm a professor of statistics at the University of Connecticut, and I'm also the new editor of Journal of Data Science. This journal just released a special issue on data science in action in response to COVID-19 last month. I look forward to receiving many submissions from the interesting talks today. The evening keynote has two speakers. Ryan Tibshirani is an associate professor in the Department of Statistics and the Machine Learning Department at Carnegie Mellon University. Ryan's interests include high-dimensional statistics, non-parametric estimation, distribution-free inference, graphs, optimization, and numerical analysis. With him is his colleague, Alex Reinhart, who's an assistant teaching professor of statistics and data science at CMU. His interests are spatial temporal data analysis, anomaly detection with applications in radiation detection and crime prediction. He also has a special interest in pedagogical research. He's the author of Statistics Done Wrong, an eye-opening book on how statistics is misused in science. Ryan and Alex both work at Delphi, CMU's Influenza Forecasting Center of Excellence, where Ryan is a lead researcher of the COVID-19 response team. They've made headlines on the work they have done, particularly COVIDcast, which displays indicators related to COVID-19 activity levels across the US. Now, with great pleasure, I give the floor to Ryan and Alex.
Thank you. Thanks, Jun, for the introduction. Can everybody hear me okay?
Yes.
Well, it's an honor to be invited. So I'm going to give this talk, but Alex helped me a lot prepare it, and Alex will be here to serve as backup and answer any questions in particular about the surveys, which is Alex's specialty within the group. So as Jun said, we're faculty at Carnegie Mellon University. I'm actually also an Amazon scholar. And I put up the slides to this talk at my website. If you look at the footer in this presentation, it'll stay in the footer the whole time. So you can just, at any point, grab the link if you wanted to take a look at the slides. All right, so let me tell you a little bit about Delphi. So the Delphi group was actually formed what feels like not that long ago, but I guess technically speaking, it is a while. It was 8 years. We formed the Delphi group to develop the theory and practice of epi forecasting and its role in decision making. And this was something that Professor Roni Rosenfeld and myself started in 2012. At that point, our focus was entirely around seasonal influenza in the United States. And the group was pretty small. It was just Roni and I and two of our students. And the focus was almost entirely on seasonal flu, as I said, in the US. And really the main activity that we participated in as a group were these flu forecasting challenges that the CDC started holding in 2013. And our group, and particularly Roni, was actually, we helped shape what these challenges should look like. So it helped us think about the science of forecasting, not just producing forecasts, but evaluating forecasts, aggregating forecasts, etc. My cat apparently also wants to give this talk with me, so you guys will have to bear with me if she disagrees with me. So so our main activity, as I said, was actually in producing forecasts that were submitted to the CDC through these flu forecasting challenges, where the target was seasonal influenza. And we had, over the years, developed a track record of success in that. We were the most accurate forecaster in many of the years between 2013 and now. And this community actually grew in size. This last year, pre-pandemic, there were about 40 different systems being submitted to this forecasting challenge. And so largely because of this forecasting work, but also because of our kind of general interest in epidemiological forecasting and tracking, we were awarded one of the two CDC Centers of Excellence for flu forecasting in 2019. So that work started actually in September of 2019. And a lot of our focus was around not just producing forecasts, but producing open source code that supports those forecasts, and also various data streams that we had put together that were kind of helpful in making forecasts for things that we supported and made public through an API that we've been serving since 2016. So if you want to learn more about our group's past work, you can just click on this link here in my talk, which takes us to the Delphi's webpage, or just search for CMU Delphi on Google. So Delphi now is very different than even the Delphi of January this year. We went from about 6 to 8 members to over 30 in order to support the COVID-19 response in the US. We added many smart folks from CMU, Alex included. We are just so lucky, that we've had so many amazing smart volunteers, but also from other universities like Stanford, UC Davis, and USC, and also from industry. So, we would be really nowhere without these additional volunteers. So all of the work that I'm going to present today is really not work that, I can take. Of course, I can't take credit for this solely, and Alex and I can't take credit for this solely. It's the work of a huge team. And the focus actually, since the pandemic became a reality for our group, has actually been quite different than the focus before the pandemic, in that it's really not been about forecasting. It's been about something that you might consider, a step that you would take before forecasting, which is data. What data sources make sense in order to even make the forecasting problem tractable? So the feeling we had was that the problem is so hard that our best weapon at this point is a diversity of data sources, right? You all, I'm sure, have been, at least many of you have probably been following, several of the prominent forecasts in the news. They aren't, they're not perfect. Let me put it that way. It's a very hard problem. And so we felt that, addressing the data issue was probably something that we could have that was, first of all, fundamental and needed to be done before forecasting. And it's actually turned out to be, a really larger part of our effort, which is more of what I'll talk about today. I won't really talk about forecasting at all today, to be honest. So COVIDcast is the name that we've given to our project, which has many parts. The first part is that we've been lucky enough to develop some unique relationships with partners in tech and also in healthcare, which grants us access to a number of unique data sources that reflect pandemic activity. All of these data sources, all the data we receive, it's really maybe our number one kind of, our number one principle as a group is that whatever data we receive, we make public to the fullest extent we can. And so all of the data that we're able to kind of access through our partners, properly aggregated, of course, and privatized, we release publicly. And so the second part of the COVIDcast project is just a real kind of large engineering infrastructure that's required to build in COVID-19 indicators from these data sources, update them continuously, so every day, and serve them through a public API. Not just serving data, we actually keep track of revisions of data. So at this point, our database that supports COVIDcast has over 500 million observations. And I'll tell you more about the data sources that go into it in just a second. And I already mentioned, a big part of this is the public-facing API, which serves these new indicators daily, and we have R and Python packages for client support. All of what I'm going to show you today, actually, all the examples I'll show you today, I've put together based on our R package for client support. And the code is all in my talk. So for the short kind of code snippets, you can just take a look directly at the code. It's here. And for the ones that were longer, I've hidden the code chunks, and you can take a look at the markdown file for this talk, which I've also put up at the same link as the slides here in the footer. It's under the talks folder. Another part of the COVIDcast project is we build interactive maps and graphics to display these indicators. So these are for public consumption, both by the general public and also by decision makers. And the very last but substantial piece, which I won't talk about at all, is all the forecasting and modeling work that's built on top of the indicators. And this is, of course, as statisticians and computer scientists, and let's say a group that whose foundations was in forecasting, this is of course perhaps the part that we're most familiar with of this entire effort. But as I conveyed to you, it's not really the whole thing at this point. It's really just one piece of a much larger effort. Okay, so before I tell you about what kind of data signals we have available through the COVIDcast API, I wanted to talk about something that epidemiologists like to call the severity pyramid. You can think about it as a way of categorizing epidemic data in terms of its level of severity. And at the very top are, perhaps not surprisingly, deaths. And so this is the latest indicator of pandemic activity is, when an individual dies. And deaths are publicly reported. So you can actually find deaths at this point. They get reported through typical public health reporting channels, and county departments of public health and state departments of public health will aggregate these and make them publicly available. And then various websites like COVID tracking, but also the efforts out of JHU and USA Facts will already serve these in a convenient format for people to obtain. Below deaths are what I would call critical hospitalizations. So these are people who are, for example, in intensive care units or being put on ventilators, things of this sort. That's maybe the one level down in terms of the severity pyramid. These are, as far as I understand, there are no, these are not reported through typical public health reporting channels, at least not at any kind of trustworthy geographic resolution or temporal resolution. And it's a lot of work to obtain these. Often state departments of public health will put these up on their dashboards, but they'll be statewide and they'll be subject to large revisions. And so another source of data from which you could learn about ICU, for example, use would be through medical records and medical claims. That's typically very hard for the average person to come by. This is a very kind of difficult data source to get your hands on it. If you're, let's say, if you're an interested modeler, it's going to be very difficult. Or if you're a public health decision maker, it'll be very difficult to get your hands on medical records and medical claims. Below that is hospitalizations, and really it's largely the same story. State departments of public health will make this, at the state level, oftentimes available through dashboards. But it's not easy to obtain data below the state level. Data is subject to large revisions when it's done through public health reporting, and medical records and medical claims are probably your best bet, but they're difficult to come by. Below that is case ascertainment. So which people have gotten, tested positive, let's say, for the disease in question. In this case, it would be COVID. That is also publicly reported like deaths and available at the county level through, very much like deaths, through efforts at Johns Hopkins, USA Facts, COVID tracking, etc. Okay, below confirmed cases is who is seeking medical care due to, let's say, a presumed infection of disease. So maybe when somebody has COVID-like symptoms, they will attend the doctor's office. And this is something that, as far as I understand, it would only be available through medical records and medical claims. I'm not aware of any other source of data that would reflect this rung of the severity pyramid. But again, the difficulty is that these data sources are not very easy to come by. Below doctor's visits or outpatient visits are symptoms. So who is symptomatic in the general population? And this is a very difficult thing to measure, as you might imagine. There have been some pretty brilliant attempts to get at this information by other researchers. So Google had this brilliant idea dating back to 2005, actually, that they could construct, let's say, signals that were supposed to reflect current symptoms by looking at the propensity of certain search terms through Google, right? So people don't tend to search for, let's say, you might imagine here, something like COVID, loss of smell, loss of taste, or some of the rare symptoms in combination with the word COVID, just for fun. That happens certainly some fraction of the time, but you might imagine there's also some signal there. That's, I think, it's an extremely interesting and potentially useful source of data, but it's also quite noisy in that it's people are in public behavior in the sense is influenced by let's say events that occur in the news. So what we see when we look at things like the these signals based on Google searches is that it sometimes can be affected by large regional or national news events. And another source here is actually digital thermometer readings can reflect symptomatic infections. Below symptoms is who is infected in the general population. So who has the disease in question? Again, potentially with or without symptoms. Very, very difficult to measure, except through, as far as I'm concerned, seroprevalence studies. This is the only way in which I know of it that these things can be measured. Grab a bunch of random people in the population, not literally grab them, but like say grab a bunch of blood samples that are sitting at a lab for some other purpose, and test them. And that's really the only way that I know of some kind of let's say random testing to assess infections in the population. And the very bottom rung is public behavior. So what are people doing that may, the causal error can go both ways. That may be something that we can view as affecting the pandemic or being affected by the pandemic. So things like mobility patterns. How often are people outside their house each day? How many people are wearing masks? To what degree do people still go to bars and restaurants, etc.? Okay, so hopefully I didn't exhaust you with that severity pyramid. I think it's just nice to kind of think about all the sources of data that you might be interested in a situation like the one we're in now. And now I'll just spell out a bit more what these things could be used for. So for forecasting, you might imagine that if your goal is to forecast, let's say, case incidence or the number of new cases that would occur some number of weeks from now, it would certainly be helpful to see things in the severity pyramid below case ascertainment. So things like doctor's visits and symptoms could be predictive of new cases in the future. And same with hospitalizations. If I'm interested in predicting hospitalizations, then I would want to look at data sources on the rungs below hospitalizations on the severity pyramid, which could help me, form better forecasting models. Nowcasting is a kind of separate consideration from forecasting. It's not asking about what's happening in the future. It's asking for a better kind of view of what's happening right now. So it's about developing better situational awareness, taking into account the idea that, let's say, things like confirmed tests are lagged, and they're also not a complete view of the current picture. So, relying on a multitude of data sources to figure out a better sense of the current pandemic activity is another kind of really important goal. And the last category I'd put here is just general epidemiological research, which a lot of times is done retrospectively. But, a lot of these data sources will want to look back months, possibly even years from now, and see if we can figure out, for example, how did public health reporting fare in the times in which we were relying on it? Where did it fail, and how can we, what measures can we take to improve it in the future? Or things like what behaviors are linked to disease spread, etc. So a bunch of different questions you could ask or try to answer based on these data sources. So jumping to COVIDcast, we actually hit on a lot of the rungs of the severity pyramid through our COVIDcast API. And it's updated daily, as I said. Some fraction of this are data sources that are data signals, I should say, that are put together elsewhere, like in Johns Hopkins team and USA Facts, for example, and we're simply mirroring them on our site for convenience, for somebody to be able to access, all the relevant data that we think there is in one spot. And others are things that we've put together ourselves, and those are things that you would only be able to find through the COVIDcast API, and that's what I put in italics here. So we have death data from JHU's CSSE and USA Facts. We don't have data on ICU usage yet, but that would be coming soon. We have hospitalizations available through medical claims data, which I'll talk about a bit later. We have confirmed case data through JHU, CSSE, and USA Facts, but also through a partner we have that is a medical device company called Quidel. We have doctor visits available through medical claims data, which again I'll talk about shortly. We have symptoms available through massive surveys that we're running in partnership with Facebook, and I will also talk about this later. We have symptom data available. This is self-reported symptom data. We don't have any data on infections. And we have data on public behavior available both through the massive surveys we're running and also through a partnership with SafeGraph, who has a wonderful kind of mobility data set that we aggregate and display publicly through our API. So most of this, if not all of this, actually is available at the county level. And for a full list, you can see our API documentation site. I've left a number of things off here just because I wanted to, make this slide readable. So this talk, in what follows, I'm going to show a bunch of examples. All of the code uses our COVIDcast R package. None of it is very long. I think the longest maybe code chunk is something like 20 to 25 lines, but I've hidden any code chunk longer than like 3 or 4 lines. But all of the code you can find in the markdown file for the talk, which I've put up at the same directory as this talk itself. The examples are meant to be demos. They're not meant to be reflective of the full power of the data. I'm not showing you, the best conclusions you can draw from any of the data sources. I'm not talking at all really about forecasting, which we've been working on for a while now, or about nowcasting, which we're getting serious about right now. They're just meant to be demos to give you a sense of really the kind of fundamental aspects of the data. So let me start with just some really basic examples. So suppose I wanted to know how many people have died from COVID-19 per day in my state, which is Pennsylvania, since March 1st. You can load our COVIDcast R package, which is the client support for our COVIDcast API. And then you can just call the main function in this package, which is called COVIDcast signal. You can specify the data source to be JHU's CSSE, the signal to be, the name of the signal that reflects deaths per day, basically, with a 7-day trailing average. And both the documentation for this package and also the API documentation provide you with, very clear kind of guidelines as to what all the data sources are, what all the signals are, what all the attributes that you can search for on those data sources and signals. I can specify that I want to start on March 1st. If I don't specify an end date, it goes up to the most recent available data, which in this case I think is yesterday. And I want the geotype to be state, and I want to take Pennsylvania's data. And so that's just this one function call, and the next line is just plotting it. And so here's what a 7-day trailing average looks like of COVID-19 deaths in the state of Pennsylvania. Another example is hospitalizations. So what if I wanted to know, what is the daily fraction of, or daily percentage of hospital admissions that are due to COVID-19 in Pennsylvania, in my state? And this is data that we put together based on medical claims available through a health systems partner. And here I'm actually showing you what it looks like for 3 states, just, for a bit of kind of variety in the example. I've pulled New York, Pennsylvania, and Texas. And so you can very clearly see New York's first wave, and things have gotten much, much better since then. And in New York's first wave, over 30% at its peak of hospitalizations in the state, we estimate were due to COVID-19. Which is really a remarkably high number if you think about it. And now you can see Texas with a kind of quite a different trend, right? Having a much higher peak in hospitalizations in mid-July. Okay, another example is cases. So let's suppose I wanted to know, what does the current incidence rate look like for COVID-19 cases nationwide? So not just for any one particular state, or really any one particular county, but all the counties. And current means, most recent available. And so here I'm pulling, confirmed case incidents from JHU's CSSE, again, through our COVIDcast signal function, and I'm plotting a heat map of that. And you get, an idea of the intensity patterns that we see across all the counties in the US. Just give me 1 second. I'm gonna tell my son to be a tiny bit more quiet. He's having a lot of fun playing. All right, I'm back. You guys might actually be more interested to see what he's playing with in this talk. It might be a refreshing change after a day full of talks. But anyways, So this was COVID-19 incidence rate, the current snapshot of the US. So just a couple lines of code produces this heat map. The next example is cumulative cases. So not currently, but total number of COVID cases overall history per population. Again, it's a cumulative case rate. Now we get a very different picture. We see that the burden in the south has been, particularly the southeast, has been a lot higher. So these last several examples were all drawn through the public health reporting data. I'm going to skip this next example. I'm going to actually now go to symptoms, which this is data available through our survey that we're running in partnership with Facebook. So this is something that is not available through any kind of typical publicly available data source. And this is what percentage of people report that they know somebody with COVID-like symptoms in my county. So my county is Allegheny County. I live in Pittsburgh. We can really clearly see that, well, first of all, we didn't actually start running this survey until April 10th, and this question wasn't added until April 15th. So that's the earliest we have this data available. So we don't know what it looked like before then, but we can really clearly see a spike here in mid-July. And there's an interesting kind of little bit of history behind this question, which I will get to later, if I have time to explain how we ended up with asking people about COVID symptoms of other people. But it tends to be a very useful signal we found. And right, so I guess I'll just mention now that this survey is not a survey we ran with Facebook to get data for Allegheny County. It's actually massive. It covers a huge number of counties in the US. And I just wanted to make that clear now in case people thought I was showing data from one survey in one county. We'll talk about the Facebook survey after we talk about the medical claims. So here's an outline for the rest of the talk. I think I have maybe 15 or so minutes left, 15, 20 minutes. So I'm going to tell you about the medical claims indicators, some of the problems we find with them, the symptom survey indicators, some examples of why these things are useful, and then I'll just kind of tell you what's next for our group and wrap up, and I'm happy to take any questions at that point. So I may have to pick up a bit. Again, I actually think that I may have to pick up a little bit on some of the details here, but if I go too fast, I'm very happy to take questions about anything afterwards. So since March, we've been working with health systems partners and have been receiving aggregated counts from claims data that helps us estimate the percentage of people who are attending the doctor each day with COVID-like illness, and also the percentage of hospitalizations each day that are due to COVID-19. Medical claims typically can be lagged up to a month. It can take a long time for an insurance, for example, to process insurance company to process the medical claims. So it depends on kind of at which point in the stream you're accessing it. We're incredibly lucky in that we have a very fortuitous relationship with our health systems partners. We see claims very early on, and they're lagged by somewhere between 3 and 5 days. What we have covers much of the US at the county level. The counts are based on ICD codes, and I'll tell you a little bit why this is not a trivial problem in a few slides. And our data is updated daily, so our signals get updated daily, but they're subject to heavy revisions, which is something I'll talk about again, why this is not such an easy problem in just a few slides. But first I want to give you just a couple more examples of what you can, some very kind of basic snapshots you can see with this data that helps you get a sense for some kind of fundamental aspects. So suppose I was interested in knowing, how do current doctor's visits due to COVID illness look like, or COVID-like illness look like? These are not confirmed COVID cases, but people who attend the doctor with COVID symptoms. How does it look currently in the southern states, compared to, let's say, mid-July, where if I followed the news, I would know that a lot of the southern states were experiencing a surge in COVID activity. And this is just a different view of the pandemic kind of, let's say, of the pandemic's progression than confirmed cases. It's measuring something at a different rung of the severity pyramid. So these people aren't necessarily confirmed COVID cases. They might be attending the doctor with COVID symptoms and may never get a test, or may get a test a number of days later. So this is what it looks like on July 15th. This is the heat map of intensity of doctor's visits due to COVID-like illness. And this is what it looks like today. So, in this one snapshot, there's quite a big difference between, mid-July and late August with respect to doctor's visits. And then here's another example. How do some major cities compare in terms of doctor's visits due to COVID-like illness over time? And so I pulled four cities: Pittsburgh, which is my city, New York, San Antonio, and Miami. I picked the last three because, they've had prominent news coverage, for example, for COVID activity. And in blue is Pittsburgh here. You can see we had a very kind of small first wave, and now have a larger but still, relatively small compared to the other cities, second wave in terms of doctor's visits due to COVID-like illness. This is New York in green, so very significant first wave and much less activity now. This is San Antonio in purple. It's a complete opposite kind of story temporally, and this is Miami in red. Okay, so this is a harder problem than you may think. Working with aggregated counts from claims data sounds easy and clean, right? It just sounds like you take a bunch of counts, and maybe get a numerator, get a denominator, divide them, put it in our API, and wash your hands. Everything's good. Unfortunately, it's much more messy than that. In fact, working with claims data is extremely messy. Something I appreciate just much better now than I did, let's say, in February. And there's really two reasons for it. The first is that, or there's more than two reasons, but these are maybe the predominant ones I want to share at least. The first reason is that there's a lot of heterogeneity in reporting. So a COVID-19 patient, whether that's someone with COVID-like symptoms or somebody who's hospitalized due to COVID-19, does not have a universally agreed upon definition in terms of ICD codes. And coding practices can vary greatly by location and by time. So it's really non-trivial to figure out basically how to construct a classifier that goes from ICD codes to COVID-like illness, or ICD codes to a COVID-19 hospitalization patient. And this is something that I think we have a colleague in biomedical informatics. A big part of his career is dedicated to understanding this. It's not something that you can just jump into and expect to come up with a perfect solution in a matter of months. Another big problem outside of this reporting heterogeneity lies in data revisions. And so I'll talk about the general problem just very briefly, and then I'll talk about doctor's visits in particular. So many data sources, not just medical claims, are subject to revisions, or what we like to call backfill. Case and death counts can frequently be adjusted by public health authorities. Medical claims data, they either take a while to be submitted by the care providers or processed on the other side. And test data can be backlogged for a variety of reasons. So many data streams are subject to revisions. This presents a real challenge to anybody who wants to model, let's say fit models to pandemic activity, like, for example, build a forecaster. It's because you have to learn how to forecast based on the data that you have available at the time at which you want to make the forecast, not somehow at a later time when all the data has been settled. So you can't just, if I wanted to, for example, do some retrospective testing of my forecasts, I can't withhold all data past July 1st, given the current data I have today, and just train on data previous to July 1st and evaluate on the next several weeks. It's because the data I would have had at July 1st is not the same as the data I would have retrospectively had for July 1st today, right? Things would have been corrected or adjusted days, weeks later, et cetera. So you actually have to understand and model the revisions if you want to produce an accurate forecaster. And here's just a very quick picture of this. I don't have a ton of time to explain it, and I didn't leave myself a ton of time for these for this example. I spent a little longer on the motivation earlier, but basically, this, you can come back to this if you're curious. This is just empirical evidence that revisions make a very big deal with doctors' visit signals, and actually they have different trends in different states. So what we usually see is that revisions tend to increase our estimates of, for example, doctor visits due to COVID-like illness, and it's because the things that get submitted late tend to be things that go into the numerator. But it's not always the case. So for example, in Arizona, empirically, it seems to be the opposite. So it just points out how hard the problem is and the need for kind of careful consideration and careful modeling if you're going to be using this data. Okay, let me skip this because it's a bit of a subtle point. I'm happy to come back to it at the end if there's questions. We have some evidence, I'll just tell you the punchline, some indirect evidence that there's quite a bit of spatial temporal heterogeneity in medical seeking behavior coming out of our the signals that we built, which also presents a real challenge to modeling. Okay, so let me get to our surveys. I think I have maybe 5 or 10 minutes here to talk about our surveys and to wrap up. Back in March, we began discussions with Facebook and Google about running surveys to collect real-time info on COVID symptoms. And in April, we launched 2 surveys. We actually launched one through Facebook and one through Google. And they are very, very different. The one through Facebook is actually advertised by Facebook, but it's run on our own CMU platform, implemented in Qualtrics. And we actually control the survey questions and the survey data directly. So Facebook never sees any of the data. The one run with Google is actually run by Google, not run by us, through Google's Opinions Reward app, AdMob, similar platforms, and they basically give us access to the aggregated survey results. It's a very different relationship. Both are absolutely massive surveys. So the Facebook one, we see about 75,000 people per day, and in total since April, over 10 million survey responses, 10 million people that took the survey. Google at its peak was actually hitting 600,000 people per day. So these are absolutely massive surveys, but they're very different for the reasons I already said in terms of the setup, but they're also very different for the following reason. The Facebook survey that we have is long, and we have no control over the sampling distribution geographically. We get respondents that click on a link that's advertised on our homepage in Facebook to take our survey, and we just get what we get. The Google survey is short. It's actually just one question long, and we have full control over the geographic sampling distribution. So we can choose where and when we sample. And so I won't talk at all about the Google survey. It's still very much a work in progress. Another time, another talk, I'll talk about the Google survey. So the Facebook survey is, I already said it reaches about 75,000 people per day and over 10 million people since April. We ask people about COVID symptoms, both common and rare, COVID testing, with more questions on testing coming soon, mental health, social contacts, behavior, mask wearing, other behavioral aspects, demographics, and it's about 35 questions at this point, so it's not a short survey. And there's a parallel international effort that's run by the University of Maryland, which runs a very similar survey. We're working closely with them that reaches over 100 plus countries around the world. And you can visit their website for access to the international data. Okay, so I'm going to skip this. This is just more details about the survey, but I'm a little short on time. I already said this. So let me jump to an interesting, a couple interesting views of the data, and some evidence that this could serve as an early indicator of COVID activity. So I pulled up case counts for Miami-Dade between June 1st to July 15th, which I pulled because, again, it's prominently featured in the news for a lot of COVID activity. And I also pulled an indicator that we build based on the Facebook survey, which estimates the percentage of people who know somebody in their community with COVID symptoms. These are people reporting on others that they see around them or that they know in their community. And the number of new confirmed COVID-19 cases per day is shown in blue. and the number of, or the percentage of people who know somebody with COVID-like illness is shown in red. And they're not on the same scale, of course. That's why there's two y-axes here, the left one for the COVID-19 cases and the right one for the Facebook survey signal. And we see two things. The first thing we see is just a good sanity check, which is that as more people are, let's say getting confirmed through the official public health reporting channels, confirmed COVID cases, indeed, it is the case that more people are reporting that they know others in the community with COVID symptoms. So that's a very important sanity check. And we see this basically throughout, that these things track each other very closely, not just for Miami at this period of time. We see something else here, which is a bit subtle because it's often hard to read signals on different scales. But if you look closely, if you take a look at the inflection points in these signals, the survey signal is flat for a while and then has a kind of sharp rise. I think this is June 19th. This is in red. Whereas the COVID-19 confirmed case signal is mildly increasing, mostly flat for a while, and then has quite a sharp rise 6 days later. So this is what we mean by early indicator, that let's say increases in self-reported symptoms or reporting symptoms of people in their community could be predictive of an increase in confirmed cases to come. And this is believable for two reasons. One is that symptoms precede let's say case ascertainment in the severity pyramid, right? People are symptomatic before they go and get tested. And the second is that confirmed cases can be delayed because it's not as easy as just taking a survey in terms of data collection.
5 minutes, right?
Okay, great. Yeah, I'm pretty close to wrapping up. So that was just one county. I pulled the top 20 counties in terms of the rise in case counts between July 1st and June 15th, and you see very similar patterns. And in several cases, you actually see the Facebook survey signal, the inflection in that signal precede by quite a lead time the inflection point you would have seen in cases. So, the conclusion from this kind of anecdotal, more informal analysis is that the community indicator is not really a lagging indicator, and it's sometimes leading. It depends on the county. I guess I didn't show you carefully, but in something about like maybe 5 or 6 of these 20 counties, there's a very clear lead that you get in the Facebook survey signal, but in others, there's not necessarily a clear lead. They seem to rise at the same time. So it's sometimes leading, never lagging. Similar results, by the way, hold with the doctor's visits indicators and other indicators that we've built. It's not just this one. A lot of our indicators are really collected with the hope of serving something like this purpose, being an early indicator. And we've found similar patterns holding with a lot of our data signals. Unfortunately, with everything, whether or not you have an early indicator or not seems to be quite location dependent. And that's a real challenge for modeling, right? Because it means that you can't put a global model across all counties that tries to predict, let's say, an increase in cases from an increase in like one of the survey signals or any of our other signals. You have to be a lot more kind of careful in terms of localizing these models. And we're working on these things now via hotspot detection or early warning systems to formalize these things rather than kind of the more informal plots I've shown you right now. Okay, so that's really all I have. If people are curious, I can come back to a slide on why I'm showing you the in-community indicator versus just the self-reported symptoms indicator. And I'll just remind you that we have a lot of other data signals, not just these ones in our API. And something that Alex can talk more about if there's questions, that if you're interested in the survey data beyond the aggregates that we make publicly available, you can apply for access through a website run by Facebook. And if you agree to data use terms and you're a researcher, for a nonprofit institution, then you can get access to actually the individual de-identified survey responses, which opens up an enormous amount of possibilities for research, whether it be in public health or something else. Okay, so very quickly, what's next for us? We have actually bigger and better medical claims indicators in the pipeline. We have lots of work to do in the Facebook survey, going beyond the core set of symptoms, building indicators out of many other things on the survey, using the survey to shine light on how people are responding to the pandemic and who it's affecting the most. We have some plans for the Google surveys, which I can mention if people are curious. And of course, nowcasting and forecasting are a constant battle for us. We're just always working to improve our nowcasting and forecasting models, putting these indicators to the best use we can. Some very quick lessons learned. When you run a survey that's big, you get a lot of emails, and sometimes those emails, the senders forget to be polite. Really surprised me. But more seriously, there's a lot of spatial temporal heterogeneity, which I touched upon just a little bit in a lot of these indicators, which poses big modeling challenges. That's something to pay attention to. More broadly, it's our kind of one of our principles or one of our kind of core, it's one of the core ideas that we work around in our group is that one of the most important steps to find the right answers is getting the right data. And this is what we spend a lot of our effort on, and it's not easy, but we think it's worth it. And now I want to invite you to help us find the right answers. It's not something we can certainly do by ourselves. It takes an entire community to find the right answers to all the important questions. Of course, there are many, many groups doing amazing work already. I just want to invite you to join the community and take a look at our data, see what you can make of it. And a big thanks to all of Delphi and to many of our sponsors, particularly the CDC. So thank you.
Thank you, Ryan. Let's take some questions. First question is, you are providing data via an API. What issues have you found with storing and serving this data? Is your AWS fellowship aiding in this process?
Not really. I'd say I'm probably the least database savvy person in all of AWS. It's extremely challenging. I'll maybe say a couple things, and Alex can jump in as well, because I know Alex has, knows a lot about this. We basically have found that I'll say maybe the background, and Alex can tell you what we're doing now. The background is that we've been doing this since 2016, but we were doing it by running a server in my colleague Roni's office, and we had a public API since 2016 to serve flu data. And really the only people who cared about flu data were the 25 or so teams that worked with us in the CDC on flu forecasting. And that was it. And so there was essentially zero traffic and very easy to maintain. And when it went down, we get an email from a friend of ours, and they would let us know, and then we'd fix it. Now it's very different. Alex, do you have statistics off the top of your head about the number of API calls per day or anything even related to that?
I don't have any recent ones, unfortunately. Back in June, we were getting on the order of millions of API calls over a few weeks, and I think it's only increased since then. I'll say, to me, the biggest challenge has been, as statisticians, academics, often the type of work we do is do an analysis, write up some code that does some analysis, and then you finish it, and then you're done. What this calls for is more like engineering on the scale of you've got to be able to write something that runs every day automatically, reports its failures, manages the database running out of disk space, and manages all these problems automatically and without requiring some poor graduate student to press the button every morning to run the code. And it's a very different type of engineering that we've had to very quickly adapt to and learn how to do and implement.
Might the plethora of data sources and the visualizations tend to confuse people and policymakers?
That's a good question. So what I presented today would not be what I would present to certainly some of our partners in public health, depending on their background. We do interface pretty closely, for example, with our county, Allegheny County. And we have meetings where we basically try to extract from them both what they need and how they would consume it. And so we're kind of building tools on the side that you might not see through public display to better serve their needs. We've also talked with a couple state departments of public health and of course with the CDC. Our contacts at the CDC are very quantitative though, so I guess the short answer is I don't think a plethora of data sources can be confusing. I think that's probably only to one's advantage if one understands, let's say, the stipulations that come with each data source in terms of it's what it's showing and what it's not. And we try to make that very clear everywhere. The presentation is certainly something that, we also pay attention to. And at this point, like this talk, for example, was catered to a more quantitative audience, but you're right, absolutely right, that it would be, it's important to kind of know your audience. And I think this is something that we are committed to and are, on a better path right now to kind of producing more digestible tools.
Have you talked to any epidemiologists about why this kind of pandemic hasn't happened before except 1918?
I feel entirely, unqualified to answer that. I would say virology is pretty distant from the type of epidemiology that we, or the epidemiologists that we interface with, which tends to be more on the public health side. So I would only be guessing. And if you and I are having a conversation, you and I and Alex, I'd be willing to give you the, whatever random gut feelings I had, but I probably shouldn't comment in a plenary talk.
Yeah. Are COVID prevalence estimates publicly available in it, in your work?
Prevalence estimates, you're saying?
Yeah, COVID prevalence estimates.
Yeah, so you can find, so we don't make COVID prevalence estimates, but we make, so the symptoms offer estimates of the prevalence of, people with COVID-like symptoms. So you can see estimates of the fraction of people or the percentage of people in any given location at any given time that have COVID-like symptoms. Now, I kind of glossed over this, or maybe didn't say this explicitly, but it's important to mention now that you asked me. There is a survey bias here that we cannot control for. There's actually two sources of bias, and really only one of them is even possible to control for. One is the fact that we're surveying people through a sampling mechanism through Facebook advertisements. And that's not the whole US, that's just Facebook users over 18 who are allowed to take the survey. And it's not even a uniform sample of Facebook users over 18, it's actually users that were inclined to click on this link. Maybe who had interest in survey taking or had some altruism or interest in public health or some other, mix of that or other reasons. So the sampling distribution is not, uniform at random from the entire US population. And that we try to control for in part by Facebook basically has helped us design a kind of debiasing mechanism for that. I'll just put it that way. The other source of bias comes from self-reporting, which I think is not really something you can correct for at all. It's just unclear to me what fraction of people understand the questions that are being asked and are being truthful. So all this put together, if 10% of people report that they have COVID-like symptoms in New York on a certain day, it's unclear to us what that number means in any absolute sense, but the variations over time are still meaningful. If you think about this bias being temporally constant, then day-to-day trends are still meaningful. And this is why we tend to think of it as an early indicator, because that's all kind of temporal.
I think that's all the questions. Let's give a big round of applause to Ryan and Alex.